So we're going to start off and just do a really quick review from the beginning to the end of the process. So the major component is, of course, recruitment. And we've made it our commitment to try and reach out to unheard voices, and that means a very different strategy in terms of recruitment. We're really trying to sponsor students to be able to cover their costs and provide extra mentorship to really encourage people who have been engaged or have tried to engage in the healthcare system in a new way. And these are our criteria. Yes, it is very helpful. You have to know how to use a computer, that's a given. You have to know how to learn to write. But these are really this is the essence of what we are. People come to our programs, our formal training, because they have a patient or a family experience. They come because they're really interested in research. The other day, I said to a group that people had to be curious and anal at the same time. You know, we're looking for people who have a real thirst for why things happen. You know, and that's pretty evident with most of the people that make it in our program. That commitment to healthcare reform, not to further their own agendas, but really to work with the system to make the changes that are needed. And of course, the last one is the commitment to be part of the training, right?
So I was part of the first cohort that started roughly 2 years ago, and I came with a chronic condition of osteoarthritis. And I wanted to explore a way to influence the health system in a non-traditional manner. So we are professionals, business people like myself with an MBA and government policy perspective.
And we started out adapting a training methodology that was developed through a CIHR grant related to teaching seniors how to become more engaged in research. And so what we've done is we've adapted that method to really move into the area of patient engagement and in research. And it's been quite a big challenge. But as of January, for those of you who are interested in becoming students, we are offering an undergraduate and a graduate internship in this area. That includes both a theory course and a full course, like 2 half-course internships that really involve working directly with the development and the carrying out of a research project. That's a funded project, so it's a pretty realistic experience, isn't it?
So for me, that meant 160 class hours, outside readings and assignments, and lots of time actually working in our research groups. And during our internship, small groups designed and conducted research that reflected our concerns as patients.
So the methodology is pretty simple. This is the framework that we work within. It's a methodology that starts with a set focus group of representative patients who have an interest in the topic, and they help us to refine the question and to really hone the methodologies, and they really help us with recruitment strategies. All right, so they become almost our advisors. That then leads into a collect phase, which has a wide range of combinations of qualitative methods. Everything from new methods in participant observation to really structured and creative ways of using focus groups as research, narrative interviewing. We're getting more into creative processes, doing environmental scans, working in priority setting methods, etc. So then this group reconvenes, and what you'll find is that people from the set group join the reflect group and are joined by people from the collect phase. So it's a coming together, and at that time we really look at the preliminary analysis with our patient advisors. They help us to interpret the data, to really look at the KT potential, where we should go with this data, how to really engage with patients and their families. And I guess, why don't you just tell them a little bit about...
Sure. So the team I worked with started out to investigate wait times in OA, because that was a major issue for the Bone and Joint Strategic Clinical Network at the time. So the SET process revised our focus to waiting for help with OA. And Collect used focus groups and narrative interviews, and the Reflect stage helped us to see a common metaphor across all the groups.
These are just some of the research projects that we have completed. They're available online in full research reports, and we've now got a publication strategy where we're moving these reports into a book that we're working with the University of Calgary Press with to show the kind of research that can be done in an engaged way. So we're quite excited about moving it that direction, and hopefully we're also moving into being able to use this as a foundation for a special issue of The Patient. We've been negotiating with them to produce the first formal academic publication in patient engagement research. So now we're going to become the, I'm Cher. Does that mean you're Sunny?
She's tall for us.
Oh.
And he's dead.
So I get to become the traditional researcher again. So I'm going to go back to what I used to be, and you'll find out very soon who Colin has become. Oh, as a traditional researcher, I decide the question. I mean, I know what the funding requires. I know where I'm going.
So we work with patients to frame the actual research questions.
Oh, but I have adapted my methods to include patients where it's appropriate.
And we bring methods designed specifically to engage patients.
Oh, but I do train patients to administer my questionnaires.
And that's nice, but we collect and analyze the data together.
I provide feedback to patients if they're interested when I'm done.
And our method ensures that patients are engaged in interpreting the findings.
Oh. Well, when I publish, I do try to acknowledge patients and what they have contributed to my work.
And we report our findings online and through social media, and we're presently creating a process for publishing together with our academic partners.
This is what it's all about, though, this next piece, and that's really what we've learned. It's hard work. This has been an enormous journey for all of us, patients, partners in AHS, research mentors that have been part of this, and of course the patients who are taking over where we've gone. But that hard work has really been made possible by one small advantage that we have. We've got an edge. We're in the Faculty of Medicine. And that always helps. And not only that, but we've been blessed with support by the senior levels of the strategic clinical networks. And without them, we would not exist. You know, we've been able to work collaboratively and to grow together. As they've developed, we've developed. And that's been really important to us, isn't it?
So our commitment to learning this method was matched by our teachers and mentors and the actual healthcare system. And I came to this work concerned about the lack of patient voice. But through the process, I now feel we have a way to constructively engage patients in a powerful way as system collaborators, especially through the strategic clinical networks.
Yeah. Colin, do you want to tell them a little bit about what you're doing with now that you've graduated?
Now that I've graduated, well, I'm now starting to work with Peter Sarkis and Maria and Katie and Jamie as a crew to look at the development of an e-tool for individual patient planning processes. So that's what I'm working on now. And that seems to have adjunct components that might also reach into some other things.
And you're also involved in the cardiovascular development too, aren't you?
The core committee of the strategic
Yeah.
network.
And we do have two wonderful, large, huge projects in cardiovascular that
Yeah.
Colin and his growing team of assistants is starting to look at. So our major learning is we've become an incubator. We've become an incubator of a new idea and watching it actually take fruition. And what it is it's a new science. And we are looking for partners. One of our partners, of course, is the Institute of Public Health. We are a program within the Institute of Public Health and really benefit from that collaboration. We've just been doing some podcasts where, what can I say? As of this morning, we are tied for the most downloaded podcast in the Patient Safety Series. And who said we couldn't hold our own? But, so that's who we are now, and this is what our goals are as a formal program. We've got a wonderful, diverse strategic advisory committee that's helping us move forward and helping us apply for the patient engagement platform within the SPOR grant. I might say just sort of on the side if you have any influence. So this is basically where we're going. And the final piece, I think, is turning it over to Marlyn.
I guess what I get to do is help you understand what it's like for a patient, and obviously I am a patient, to morph into, with the help of Nancy and Svetlana and a wonderful training, absolutely fantastic training, to morph into a patient engagement researcher. So I'm a retired therapist, which really means that I'm really used to engaging people, you know. In fact, my last job, before I had to retire because of my OA, and also they ran out of money, was that I trained social workers in BC how to be collaborative and engage collaboratively with their clients. So I thought, hey, no problem here, right? I know how to do this. I have all the techniques. What absolutely amazed me was I didn't need any techniques. I needed nothing. I sat down and I had instant connectedness with these people. Now, I did not disclose anything apart from, yeah, I have osteoarthritis. And it's pretty obvious, and it was more obvious when I was doing the interview, that I did have osteoarthritis. However, I didn't use any disclosure. So I was surprised. What I got and what we got, Mary and I, was this instantaneous connection because we had an experience, a phenomena, which was our OA, shared with these participants. And we were really surprised with our SET group, you know, that first focus group, because what happened was these people just dove straight in. They didn't start saying, well, I have a little difficulty here, or, you know, the easy stuff. They started telling us about their broken dreams, shattered lives, how their careers had been affected, how they couldn't do what they wanted to do. We just sat there and listened because we were able, they trusted us in some way to hear what they were saying. So these are some of the things we were told. Many other things, you know. One thing that was surprising was this quote: "You've understood everything I've said. Your body has told me that." And I'm thinking, my body has? And then I realized I move in certain ways because of my osteoarthritis. So do the people I was interviewing. We were mirroring each other. And I don't know if you know about interviewing. When you mirror, you open. And so we were able to get information that way as well. Is patients hide. We found this one piece of information. Well, found a lot of pieces of information. This was fascinating. People with osteoarthritis don't tell anyone they have it, especially in the early stages when they really can hide it. Not only don't they tell people, they also perceive that they are hidden by the way society looks at osteoarthritis. You know, and I'm not going to go on about osteoarthritis, but it's just we got this information. There's a perception that people have that, hey, it's no big deal. It's just osteoarthritis. You get it when you get old, you know. Well, I had participants in our study, Mary and I, who actually, their actual age was 30, 35. Age of onset varied from 25, 20, right up to 60. So I mean, we just had everything. That's an example of what we can reach that potentially another researcher would not reach because we were trusted with this information. This piece, in the literature does state very clearly that people with osteoarthritis tend not to seek help really fast, tend also to be misdiagnosed a little bit now and again. Again, there's this piece of, you know, well, you're getting old. At 40? I don't think, you know, there is. So there is a reluctance, and we were able to explore this. There's a reluctance to talk with a physician or a healthcare provider because they feel ashamed. There's a shame around having this particular disease. And this lady here who said she'd been going to doctors. This was the first thing she told me. First thing she said was, I'm so glad. I want someone to listen to me. I need to talk to someone. So we did have information that potentially would be difficult for other people. The effect on me as a patient. Well, first things first. I was taught by Svetlana and Nancy that I am a patient. And I have to be exceptionally careful. Because as a patient, I only have a limited amount of energy. And therefore, I have to learn to balance my life. And quite frankly, my life is better balanced after my 18 months doing this course than it was before. Because I learned how to be a patient as well as a patient researcher. And I build in my downtime to any estimates around any research I'm going to be doing or any job I'm doing for Nancy and Svetlana. I build that time into my estimation. So that's very important. We all know that in qualitative research, the researcher is the instrument. This means that the instrument, the researcher, has to be very, very aware of what is going on as they are interviewing the patients who have the same disease as they have. You have to put yourself right at the back of your head, which you do as a therapist, you know. You put yourself right back here and you leave it, okay? You have to be very vigilant around self-disclosure. I do not want to get in the way of my participants in the studies I do, telling me what they want because I'm so busy telling them what's happened to me. That's not appropriate in any way. So I must move back. But I do have a team that I can process any issues that come up. It took me probably 4 interviews to realize, for 35 years I had hidden my arthritis. I had a sore knee. Oh, I bumped my toe. And it wasn't until I couldn't get off a plane that I thought, maybe I should do something. So we've, I had to process this. Very, very important. So we need to exclude bias, don't we? Every qualitative researcher has to look at bias. We have to be exceptionally vigilant as patients because, as someone told Nancy, aren't patients biased? All qualitative researchers have some biases. We need to be extra vigilant. And you can see from the list that we do here, we engaged in every strategy we possibly could in order to produce valid and reliable qualitative research. This is important to us. We actually used phenomenal reduction in the study I did with Mary. And as Nancy alluded to, there were many different ways that some people produced narrative scripts, some people observed in different ways, participant observation. So in that collect phase, you have enormous flexibility. We used phenomenal reduction and we followed every step very carefully, keeping all the audit trails and everything else. So lastly, what do we get when we do patient engagement research? You get to hear the patient voice, don't you? You get to hear what they want you to know. Not what you think you want to know and asking questions, but what they actually want you to know. As Nancy said, that's how this works with the first focus group, the set focus group. So remember, we also are able to do that piece around checking our data, checking our emerging themes, checking our scripts, because the last piece, the reflect focus group, is integral in all of our research. So we always get that piece. You know, patients have been left out in the waiting room, haven't they, for quite a long time. Now patients are here, and we can be collaborative and contribute our research to healthcare reform, and we are very happy to do so. And we do so in a way that is valid and reliable for change to happen. Thank you.
So I'm just going to talk a little bit about where we are now and what we are planning to do and how to join us. So we have tested this method and demonstrated how it works. And you just heard some reflections on these results. So now that we're ready to be of service, the PACER program is providing partnership to research projects or research teams or community organizations that want to integrate patient voice in a meaningful way into the work they do. So why is it so important that we are here for you and for different research teams? It's, first of all, this method has been specifically designed to engage patients and families into research processes. It has been tested and some results have been demonstrated. PACER can facilitate the integration of patients and families into research processes in a purposeful way, meaningful way, so that it's not just having one or two patients telling their stories, but rather there is a group of trained patient researchers who collect data and capture the input from larger numbers and broader scopes of people with the same experiences. There's a difference. In PACER program, patient engagement researchers, or PACERs as we call you now, get trained to collaborate with health researchers. So these processes begin from the very beginning of the training, and people get integrated into this culture of health research so they can collaborate with the research team, which is an advantage. And another advantage, and I think you understood it from Marlyn's presentation, that patients don't only get used as tools for collecting data, which is very important actually, as Marlyn mentioned, because there is this connection that patients can get the data that cannot be received in another way. But also patient researchers are trained to get involved in the analysis of data, in the interpretation, in collaboration with health researchers, which is a different step. It usually isn't, doesn't get into processes in the regular traditional methods. And as a program, what does PACER do? If you are representing a research project that wants to engage patients, we provide consultation. We try to get engaged really early into the process of designing research projects, so that the methods are kind of merging and patient engagement techniques can get integrated. We also discuss ethics review procedures because it's a little bit specific, so we need to do it in the beginning, and all other processes that are involved in the design of the projects. Second, PACER program provides capacity because we have access to trainees, and we try to match people with similar experiences and expertise with a certain context. And we provide supervision throughout the project. So from the initiation, PACER mentorship would be provided to the emerging processes of research. And there are two major streams kind of to get involved right now. Nancy mentioned that internship can be used as a tool of actually conducting patient engagement research, patient and community engagement research component within existing research teams or organizations. If you sponsor a student or a group of students, there is trust attached, of course, because it's a very intense process and it's expensive. But these research projects that Colin mentioned and Marlyn described are actually internship projects. They were done in collaboration with Penman Joint Strategic Clinical Network. From the very beginning, they actually sponsored us, kind of. So this has been tested. So this is a 1-year-long process of training. And during this training, the group of trainees or interns will conduct something in collaboration, conduct research project in collaboration with the sponsor. So that's an advantage. And I put this stream in the beginning because right now we have so many requests from different teams, and we have only 21 trainees who just graduated, so they are very busy, and we need to develop new capacities so that we can continue this work. And the second stream is just to use the skills that are already there and hire patient and community engagement researchers or PACERs into your research structure or infrastructure. And we call those pieces of research units. So you can purchase a unit, and it's very flexible. We talked about the flexibility of the techniques, and it will be adjusted into the scope of work, into the target populations. Your research questions will be discussed, negotiated, and included seamlessly, hopefully. And some research programs are so big and they have multiple dimensions, so they would like to use a few units in their structures, which is also possible, and we'll adjust that. So we're working on developing all these things right now, and well, we're ready to work together.
Great.